Good morning, all of you. Welcome you to the CPD webinar series organized by the Society for Health Research and Innovation. I first like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:45 a.m. for you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and these CPD points are strictly adhered to the NCCPD guidelines. And from this webinar onwards, there's a small change in the way you receive the certificate. From this webinar onwards, you will instantly receive the certificates once you fill the Google form. So kindly use the format of initials followed by your surname without any prefixes. And these rules are to improve and maintain the standards of the CPD programs conducted by the Shri. And you can ask the questions at the end of the webinar. And if you have very specific questions, you can email us on office313@gmail.com. Today our topic is diabetic foot ulcer and venous ulcer, which will focus on foot and leg ulcer management with basic concepts and also pathophysiology and management principles. Our guest speaker today is Dr. B. Saseekaran, Vascular and Transplant Surgeon, Vascular and Transplant Unit of the National Hospital, Kandy. Over to you, sir.
Hello, good morning. Can you hear me?
Yes, sir, we can hear you.
Thank you for your kind introduction. Okay, thank you again. I'm Saseekaran Balasubramaniyam, one of the junior vascular surgeon for the country, working in National Hospital, Kandy. Today, I'm going to talk about foot and leg ulcer, which is, I would say, sometimes some people ignore, some people attend late, or we are not sometimes giving that much care compared to almost similar significant other disease, kind of heart attack or stroke. So within next 45 minutes to 1 hour, I will try to show my experience or the basic principle of managing these ulcers. So today my topic is mainly diabetic foot ulcer and venous ulcer. Why I confine to that is because if you see other two ulcers like ischemic neuropathy, yes, they are under the umbrella term of diabetic foot ulcer. If you just see the diabetic foot ulcer, I think you are almost covered entire ischemic and neuropathic. So the venous ulcer, that's the majority of the leg ulcer. So we can't miss that. So that's why I have included diabetic as well as venous ulcer. The rest, just that is for experts. This is my principle of ulcer treatment. If it is wrong, just leave it. But this is easy way to remember or manage any ulcer. So when a patient comes to you with ulcer, you have to think about taking something out, giving something, and treat the cause. So this principle is almost you can apply to any ulcer, and usually that is the way we manage. So infection, pus, that all know, foreign bodies, sometimes this is the factor which always bring the patient back in months, years, back to you with repeated discharge ulcer or sometimes extensive infiltration. Then debris, necrotic tissue, that is also kind of infection part. The main part, the first blood supply, has I'm a vascular surgeon, I won't forget that to give a first priority. But that is again foremost for any ulcer management, any wound healing. The second part is the one we tend to forget, the nutrition. Any patient in this country, when they are having ulcer, I'm not talking about this high class. The patients come to you, mostly they are nutritionally poor. So when you are treating a patient with ulcer, always think you can't do wonders without treating their nutritional deficiency. So give importance to nutrition. And I have mentioned supportive environment. This includes any form of dressing and kind of offloading, all sort of things coming under this. Then finally treat the cause. If there's a cause, arterial or venous or any other cause, treat the cause. So this is to keep it simple, and this is just kind of tick box when you see ulcer. Okay, there are something I need to take, there are something I need to give, and I need to think about the cause if it is not healing. Then yes, we will move into diabetic foot ulcer. These are the few patients recently I have treated or I have come up. So don't like there are a couple of white legs, so those are, I recently came from UK, so these are a couple of patients from UK and a couple of patients from Kandy and Ratnapura who I treated recently. So if you see, and on the other hand, one thing to remind, these are kind of treatable or kind of for a vascular surgeon. I would say there are big or good number of patients. They are coming with late presentation. I haven't included here to make my presentation colorful or starting with a very bad introduction. So these are kind of ulcers you can treat, and you can kind of give a good outcome to the patient. Something about diabetic and the foot ulcer around the world to remember the figures. In 2019, around 1 in 4 adults have diabetes, and again 1 in 4 of the diabetes will develop foot ulcer during their life. So foot care advice is important for any diabetic patients to prevent the foot ulcer formation. And 85% of all major lower limb amputation is preceded with the foot ulcer. So when you see a patient with diabetic foot ulcer, this patient might be a candidate for future or early amputation. So we should take care of this patient if we can for a limb salvage. Again, every 30 seconds around the world, there is a person with diabetic losing their leg. So that is a horrible figure. Okay, we will move to pathophysiology of diabetic foot ulcer. There are few things we should understand when we treat diabetic. That is a multi-system disease. It involves nerves, blood vessels, and infection. We all think about infection. Nowadays, we are thinking about blood supply as well, but sometimes we tend to forget the nerve supply, which is also contributing to the ulcer formation. So when you see the new neuropathy, these patients, so this is like a full package. So when you see a patient with neuropathy, you can diagnose all kind of neuropathy in diabetic patients. They have sensory neuropathy. That is the one come like prominent, and we all diagnose that. They always say it's numbness or tingling. Sometimes they say they can't feel anything. So this is all easily diagnosable, and this is sensory neuropathy. Then the motor neuron. So there are small muscles, there are motor muscles, small muscles get affected, and they develop cloying of the. See the second photo, which shows the cloying, and then because of that, their pressure points varies, and they get the pressure difference make the formation of callosities, or that favors the formation of callosities, and again it can be a trigger point for an infection. On the other hand, again they develop autonomic neuropathy as well, which prevent or cause the sweat gland dysfunction, lead to dry skin, which is again favors the infection to get involved with this. And on top of this crack also get involved in infection. Second thing is the ischemia, which again nowadays we are a bit good at it. Still there are patients coming with late presentation after this kind of toe. You keep on doing toe amputation, couple of toe amputation, 4 foot amputation, then some only we realize whatever I do, there is no blood coming from the foot. Then only we tend to check the pulse. But this is in the past. This is now going away, but still there are few patients coming after repeated wound. Then we check the pulse and see, this patient. So if the patient is lucky, patient might be having intermittent claudication or rest pain, then it's easy for the clinician to diagnose, or the clinician usually check the pulse. But if the patient is unlucky, patient might be asymptomatic, might have seen vascular surgeon in the past for asymptomatic absent pulse, which usually almost 100% managed conservatively. So they know when the patient come back with the ischemic or diabetic infection, after a couple of years, everyone forgot about this ischemia. So that time, this patient is unlucky. This infection spread quickly in a ischemic wound and all the damage within a short time. But if it is kind of this presentation, we tend to check the pulse, or the clinician tend to check the pulse. So gangrene or tissue loss, yes, usually alarming, and which make you, yes, there is no blood to this. Infection, this again, when diabetic patients, these are like viscous ischemia, infection, and again neuropathy, all kind of they go on. So infection, there are a lot of factors. I'm not the pathologist to tell all these things, but yes, there are a lot of factors contributing in and out. Trauma, skin breakdown, that again, discontinuity of the skin, easy chance of getting an infection. On the other hand, the neutrophil, even though their numbers are okay, but they are non-functional. They are all kind of functions impaired in a diabetic patient. On top of this, these patients, their glycemic control is sky high. So again, which favors the infection. So when we see a patient with diabetic foot, these are the three areas we try to understand or try to manage these three. So a patient come to us, first, yes, we have to assess the patient generally, whether patient is ill or whether patient is in sepsis. That I will come to that part later. But generally, always better to check the neuropathy. Usually, they have callosities, which should alarm us. Yes, some neuropathy. And on top of that, they can have deformities because of non-functioning small muscles. And you can check the vibrations sense, and their neuropathy is glove and stocking. You can check with 10-gram monofilaments. I think these all for the exams, not for the clinical management, but at least we should diagnose this patient is having a neuropathy. And always, as a vascular surgeon, any patient come to me, I usually document. It's too much for too much to ask from other clinicians, but at least when they have any leg or foot symptom, better to check the pulse. So that change the entire management of a patient. And the next one is ABP, eye or toe pressure. This is again too much to ask from other clinician. Even still, it's not freely available for the vascular surgeon in most part of the country. But again, this is good if a patient come to us with ischemic symptoms without an ulcer. These are patients, they are high risk. So yes, that is also very good, I would say, kind of examination or investigation. It is a kind of bedside investigation, you can call it, so very useful. These are high risk foot neuropathy. Yes, we already discussed absent pulse, deformity. If the patient had a previous ulcer, sometimes you have to consider them as also high risk foods. They might have some remnant of any kind of maybe infected bones, debris, and their blood supply might not be good enough. Again, active ulcer in a diabetic patient, yes, they are also very high risk. Management, again, we divide the pathophysiology into three. Again, this management also you have to, if you can divide into three, then you won't miss to tick this box when you see a patient. You have to treat the infection, you have to treat ischemia, and you have to you have to take care of the neuropathy as well. When a patient come to you with a diabetic foot infection, it is an emergency. And just I'm reading the highlighted first one. When a patient come to you with ischemia, foot sepsis in a diabetic patient, we call that as diabetic foot attack. So all of us are aware of heart attack, but some of us are not giving importance to foot attack. Yes, heart attack can kill. Foot attack can, yes, patient can lose the leg and also can lose the life as well. So we have to give priority to diabetic foot attack. I'm not saying don't compare with heart attack, but just you have to give a higher importance diabetic foot as well, because they are also killer as well as they take the liver. So they present with fever, purulent discharge. Sometimes if you might be able to elicit some crepitus, and you can diagnose a wet gangrene, yes, they are pouring pulse. So these patients, they need admission, you have to manage this as according to the sepsis, whatever the recent guidelines. So just a summary, you have to give fluids, you have to do blood gas, you have to control the blood sugar, whatever the way. Broad spectrum antibiotic immediately. I think the protocol says you have to give within an hour. And patient should go to the theater next available list, not next day, next available list. If it is in the night, yes, or next day morning, because you have to, this is like a extensive anaplastic CA. You have to debride, or you have to do an extensive debridement, including a minor or major amputation. Just read the last sentence. Amputation is not a failure. Don't think that you are taking the leg and you are doing harm to the patient. No, that is the treatment. So if the ulcer or sepsis or crepitus is extending beyond the angle, and you know this limp, you are just wasting the time by doing repeated wound debridement. Patient with WBC count of 30,000, diabetic with poor glycemic control, I would say you might need to take a good decision for a major amputation in that side. And don't forget, these patients, you might need to take to the theater back maybe in 24 to 48 hours to see or do another debridement. So sometimes when we see the patient, they say, okay, patient had a wound toilet day before or yesterday morning. So don't forget, open the wound and see and plan for another wound debridement if there is signs of infection or evidence of infection. Still the CRP is too high, still the white cells high, and you can see there is necrosis or abscess tissue. Go for another wound toilet and make this or control the source. And meantime, all these patients, any patients, when you take for the foot or for leg wound debridement, before that, at least check the pulse. And if the pulse is not there, when the sepsis is under control, get the vascular surgeon involved to assess the patient for early revascularization. Yes, it is not possible to do a early revascularization, but if the patient is lucky, sometimes you might cancel a couple of patients because of several other reasons. So this patient, if the patient is fit, then you can accommodate this patient then and there for a early revascularization. Again, some few things to consider when you treat a diabetic patient regarding the infection. This is the easy way we learn from our boss or guru or prof. Always try to poke something into the wound. Maybe a little finger or a mosquito, a probe. Bone probe is very difficult to find in the hospital. So mosquito, any forceps, just probe it and see whether you can hit the bone. Then that is the way to diagnose osteomyelitis. So, or don't wait for the x-rays and all sort of things. This is a clinical diagnosis. So this patient need a bone specific antibiotic in long run. And if you can, even sometimes x-rays might be normal in the early days. You can't wait to diagnose osteomyelitis till the x-ray become abnormal. So when the probe is hitting the bone, yes, it's invariably osteomyelitis. Start them bone specific or broad spectrum antibiotic. And this is, I don't know whether I'm just new to Kandy, like last 4 months I'm working there. Any patient, if I see in any ward, I ask biopsy or tissue culture. So the gold standard one is bone biopsy. Any toe amputation, the metatarsal head or a part of the bone should go for a culture, because that is the one we have to treat. And always when the patient come to you with the infection and you see something there in the X-ray, try to remove that part. Otherwise, you have to give long-term antibiotic. You don't have that facilities to give IV antibiotic for 6 weeks. So our setup, I think, better to remove the bone, excise the heads, usually heads and all you can excise and treat. And sometimes, yes, you might need to give IV or oral antibiotic for a long time, maybe 6 weeks or sometimes more, to treat a bone infection in a diabetic patient. Ischemia, that is my part. In the presence of absent pulse, yes, absent pulse, just the vascular surgeon needs to see that patient, especially if the patient is having a gangrene or an infected diabetic. So the principle of the ischemia management is you should have a basic investigation to delineate the anatomy. Where is the block? To identify where is the block. So simple one, all the vascular surgeons do is the duplex scan to see where is the pulsatile flow, which is we otherwise call it as inflow, means that which has a good direct connection to the heart, with which give a pulse. Or other way, if you can feel a good pulse, I would say that is an inflow for most of the vascular revascularization. So in a patient coming to us with a leg or foot wound, and if the patient is having femoral pulse and no pulse beyond that, usually the femoral artery, that is again a common femoral artery, is the inflow. That you can see with the duplex scan. And again, duplex, and you have to find somewhere down which is patent, but that flow is not enough up to the target. That is the outflow. So sometimes we say this patient we can't do anything. If the patient is not having an outflow, the surgeon can't help most of the time. So they can some other non-specific method rather than telling about revascularization, because you should have outflow to fix any or to do any revascularization. This is for both endovascular and concentric. So there should be a tube which is target or near to the, our interested area. It is not good enough to maintain or which is not having a pulse. That's why he is having ischemia. But this should be open. So sometimes we write this is we can't do the revascularization. Don't get me wrong. That patient is not having a outflow. Mostly this happens in a Burgess patient. You know, Burgess, they don't have, in most of the time, the outflow is the one affected. And duplex, and you can see the vein whether we can use it as a conduit to do the bypass. Similarly, we take the great saphenous vein and reverse it and do the anastomosis proximally and distally, like a cardiac CABG. That's, you can see all these things with the duplex scan. This is almost more than 50% of the vascular surgeon use in the country, because it's very difficult to get a CT angiogram to delineate the anatomy. But I would say just that is good, because sometimes you might need to wait for 2-3 weeks to get the CT angiogram. Then you plan the management at the time. patients ulcer or sepsis infections spread beyond the ankle or maybe the mid thigh, mid calf, then whatever you do is waste. So that's why, and the duplex is almost like, if you are a vascular surgeon and if you know, if you are good at your skills, usually that is more than enough. But certain patients, yes, we tend to ask for a CT angiogram, because the outflow, sometimes if it is calcified, very difficult to see, and then yes, it's better to wait before making a big cut in a ischemic leg already having ulcer, and you cut it, and if you are not going to revascularize, again there is additional burden to the patient. So in that case, you better wait for a CT angiogram. Again, if the block or the stenosis is higher level beyond the inguinal region, again the duplex is not that great. So then for the inflow, you might need to get the CT angiogram. So it is very useful, and it is almost done for each patient in overseas. But for as we don't have it, or we have it which is limited, so we use it only for certain patients. So those are the basic investigation we usually ask: duplex and CT angiogram, and assessment of fitness for the surgery. For that, better to have a 2D echo within maybe 6 months time to assess how the cardiac status. Because these surgeries, if it is open surgery, which is might take 4 to 6 hours sometimes, so need to assess. And these patients are vascular path, they have disease everywhere, so better to have an idea before embark on one certain area. Sometimes you do the revascularization, at the end patient might die, so better to have an overall idea before touching the patient. So better get a 2D echo. Sometimes if we are opening the tummy, sometimes we ask the lung function as well to assess the lung status. So those are the basic things. In addition to their basic blood investigation, we ask if we are planning for a revascularization. Just if the patient cardiac status is not great, usually if it is less than 45 to 50% with multiple regional wall motion defect, we tend to avoid major surgery. In that case, we choose to go for endovascular. That is nowadays rising in Sri Lanka. Nowadays, most of the centers, they have started the angioplasties. Still, I think majority of our patients getting the open surgery, which is great, but there are patients who need definite angioplasty. So that is now we have the angioplasty also is a growing field, and now there are a lot of options to revascularize the patients. And some patients, yes, they are fit, but open surgery not enough, then they might need hybrid, both open and endovascular. So that is about the ischemia. So when, like, one of the patient, I think this is recently, came to us after this is like rapidly spreading. Initially, I think she went to a GP with first toe, that is wet gangrene, started on antibiotic. That GP sent the patient to a vascular surgeon. When the patient come to me, it's kind of within 2 days, this spread to next 3 toes. But white cells and CRP were not bad, and it's demarcated. So the main aim was to do the bypass surgery. So she had the bypass within, I think, I would say within 48 hours or 72 hours. So, and we allow another 48 hours to see how this wound is spreading. Sometimes when you do the wound toilet immediately after surgery, sometimes you do kind of extensive, unnecessary debridement. So when you give the blood and wait for 48 hours, you get some demarcation, and then you can stop wherever you want. So after bypass, couple of days later, she had 3 toes amputated, and again within a week, the next 2 toes also gone because it's spreading infection. The bug was very virulent. Then we treated her with the kind of forefoot to midfoot amputation and had up 2 sessions of VAC and had a skin graft. Still she is coming for the clinic. But this patient, sometimes if this is spreading, it's again, you have to discuss with the patient whether what patient wants. This patient was not allowing me to take a single toe. So this patient, just sometimes you have to take the decision, but you can you can try your best to salvage the limb. Sometimes you might feel what part of the foot is remaining and what she is going to do for the rest of the life. Yes, there are some prostheses they can use, or some people they want the leg. They want part of the foot. So in that situation, sometimes yes, you do some spend a lot of hours to salvage their leg. You do 6 hours or 4 hours surgery. The next week, if you forget these things, this is going to again thrombose. So all the patients, you have to make sure patient stops smoking. But you should be a bit, how to say, you have to take the authority to tell them. Otherwise, these patients, when their ischemic pain goes, when their rest pain goes, when their ulcer pain goes, they forget everything. So always remember to ask how many they are smoking. They usually tell, yes, we were smoking 20, now 10 to no. Better always ask and make sure they stop smoking. Then aspirin. This is again aspirin and statin. These are the drug they should be on for the rest of the life. Sometimes these patients and some GPs, they stop the statin when the cholesterol is within normal or low. But these patients, aspirin and statin are disease modifying drugs regardless of their cholesterol level. So better to be on aspirin and highest tolerated dose of statin. So earlier we were giving 20, now it's trend to give kind of 40, or some people they are on 80 milligrams atorvastatin as well. And nowadays there are few evidence saying yes, you can give some low dose of rivaroxaban. Still it's not available in the government sector, 2.5 milligram morning and evening. But I think that will take maybe another 5 years for us to give rivaroxaban with more evidence in these kind of patients. So any patients stop smoking, they should be on aspirin and statin. So you do the wound toilet or debridement, couple of wound debridement, couple of toes away, and do the magic bypass. Now the blood you can feel the pulse at the angle or at the foot level. But if you are not managing the neuropathy, this ulcer is not going to heal. So best way is to say better not to walk until the wound heal, but that is not possible for all the patient. So you have to make sure the patient is educated, that patient is not keeping the wound down or pressing the wound to the floor. It depends on the site wherever. So there are footwears available. Or at least think about this. This is, you can do it at your bedside or at your clinic. This is we do, right? Oh, but whatever the way, make sure that ulcer, you can see there's an ulcer in the first web. So make sure that area patient is not pressing down. So you keep something underneath and keep a elastoplaster. And even sometimes you don't need to put magic dressing to the wound, just keep the wound closed, but make sure this patient is properly offloaded. So this again, charcoal food, I'm not going to touch much. Again, these patients, they are coming to you with the features of osteomyelitis. But if you do a wound debridement, you might end up in losing the leg because these keep on giving discharge and fracture. So this is non-infective inflammatory arthropathy. So they have arthropathy, inflammatory disease rather than infection. They have all kind of fractures and everything. I would say these patients, if you see this kind of patient, better not to touch. If you do a wound debridement, invariably they will end up in losing the leg. So main treatment is proper offloading. So they should get whatever the cost, total contact cost. Nowadays there are good offloading gadgets, so they can use those kind of things. And just there are anti-resorptive therapy available. I'm not going to touch, I'm not expert on these. Sometimes just they might need a corrective surgery by the experts, not for the routine work. So here, if you see, like patient might come to you with the red hot foot, typical like osteomyelitis, cellulitis, but usually their white cell and CRP are normal. So if you see this kind of patient, yes, you can argue sometimes diabetic patients, their CRP white cells might be normal. But these patients, their food is not on normal shape. If you take X-ray, there are old fracture changes. So these kind of patients, because if the white cells and CRP normal, right? If you are not doing a wound debridement, thinking that this is osteomyelitis, you are not legally, you are not doing any harm. So better to wait and get some expert opinion. So these patients need further imaging, MRI, bone scan, lot of things. And main treatment is rest, offloading. Yes, coming to this topic, this is the important factor of message. Patient should be educated. Any patient with diabetic, when the patient meet a clinician, we have to educate these things. These are simple, but we tend to forget, and patient come to you with a very bad ulcer. So they should daily inspect their feet, and in and out of the house they have to use footwear. And if they are very keen, I would say that footwear should be the toe side. The footwear should extend beyond maybe 1 centimeter, because these patients have neuropathy. Even the way they wear the footwear, if they go and hit the wall, they won't feel pain. They develop ulcer, gangrene, whatever it is, and they won't notice. So the footwear, the rubber part should extend 1 centimeter beyond the toe level. That should be ideal. And they should wear in and out of the house. So inside the house also they have to wear, because they are only they. walk barefoot and make all these kind of injuries. And daily they have to do the food inspection and keep the web space dry to avoid fungal infection. And if they feel that they are dry, they can use some moisturizing cream to keep it moist. And more importantly, when they cut the nails, they have to cut the nail straight, not curve, which end up in growing toenail and nail infection. In summary, as a vascular surgeon, always examine the pulse when there is a diabetic foot infection. Treat the diabetic foot infection as an emergency, like a heart attack. Give responsibility to the patient, right? Whatever you do magic, make sure the patient is aware about their disease and about their foot. So I will stop here, and there are a few slides about the venous ulcer, or if you want, I can continue and finish that, and at the end we can have the questions.
Thank you for your excellent lecture, sir. There are a few questions. So some of these questions have been answered during the lecture. That these are the questions sent by the participants when they are registering, sir.
Right.
Some questions I highlighted. What are the locally available dressings that could be easily prescribed to individuals for the management of a diabetic foot ulcer?
Okay. Simple way. Yes, we almost all the dressings are expensive nowadays. So I would say, first thing, we have to make sure there is no overt sepsis. That patient need admission or need a wound debridement. Then to apply a dressing depends on the wound condition. So if the wound is oozing much, if the wound is pouring fluids out, then you have to keep something to absorb it. So whatever the dressing which has foam, I would say foam dressing for a pouring wound or discharging wound. So sometimes if you see a patient had a wound debridement, then after a couple of days, the wound is greenish and it's you diagnose without the swab, you can diagnose that is Pseudomonas. They pouring fluids. Then you have to think about some foam dressing, or if they are in the ward, then think about daily changing the dressing, because dressings all expensive. So I would say, if you think about, okay, first we will keep like this. First, if it is a oozing wound, foam dressing. I'm not going to label any name. All are expensive. Depends on the availability. You use the foam dressing. If the wound is dry, then you need to keep some moisture. So if it is dry, kind of dry necrosis, then just apply a betadine, touch it, and keep a Vaseline ghost, which will keep as the environment moist. So these are the simple things. But more than, if it is oozing, you admit the patient, think about using acetic acid, because there is some microorganism inside, most probably Pseudomonas. So you give some acid, 1% acetic acid is ideal. Change the dressing daily, maybe twice daily, couple of days, and usually this oozing settle, and then go for the routine dressing, whatever depends on the condition.
Next question is,
Okay.
what is the grade of tubic grip bandage?
What is the?
What is the grade of a tubic grip bandage?
Okay, tubic grip bandage, I would say, that is, I haven't started. The next topic is that. Okay, tubic grip depends on your need, class, which grade you are going to use. It depends on what patient is having. If the patient is having venous ulcer, yes, you can go for class 2. But again, if the patient is having the post-thrombotic limb, sometimes you can go for a class 1. But usually this class 2 is the one you can manage easily. Class 1 you have to monitor. It's easy to manage and it's easily available. but it is for venous ulcer with a non-ischemic wound. So patients should have proper arterial supply.
Next question is role of antibiotics in diabetic ulcers.
Yes, any acute sepsis, they need antibiotic. Ideally, we should have culture before antibiotic. And sepsis, you start with broad spectrum and narrow down according to the organism, according to your hospital policy. Some hospital, there are certain organisms, they are resistant. So you have to adhere to your hospital policy. And usually, if it is outpatient, you have to think about what we are treating. I like already told you, if the wound is probing, and if you can probe to the bone, then you have to think about long-term antibiotic. So in that case, you have to explain to the patient. Patient usually stop antibiotic after a week, but these patients, if we are managing without removing that osteomyelitic part, better they should be on long-term antibiotic. I am not going to label antibiotic name, but just they should be on long-term antibiotic. Any diabetic patients, you have to monitor how they. So it depends on your assessment. A single day, it's very difficult to give a antibiotics. Sometimes the patient come to you for the first time. You have to assess, including the blood counts, and see. You can clinically diagnose whether this patient is having infection. Then depends on your assessment, you can start antibiotic. Yes, antibiotic has a place in diabetic foot ulcer, and ulcer means diabetic foot infection. Yes.
What are the nutrients needed for wound healing?
I am not the nutritionist again, but my policy, any patients, to think about protein. These patients are protein malnourished. So think about easy way to replace protein is egg white. So if the patient is having a huge ulcer, I would say sometime for a day they have to take 3 or 4 egg white. That is to replace protein. But having said that, I am not the nutritionist. Just if it is really needed, we can get the advice from the nutritionist. And think about the micronutrition as well. So wound healing, usually you need zinc, vitamin C, selenium, or so think about the micronutrition as well. So usually I give a multivitamin. This check the multivitamin whether this has all these three, and tell the patient to take at least 3 eggs per day minimum.
Next question is management of a diabetic foot ulcer or venous ulcer in the primary care setup and the red flags to be sent to the secondary and tertiary care services.
Any patients, if you diagnose sepsis, I would say marginally wound infection, you can manage at your primary care setup. So you treat the patient, think about bedside wound debridement, and check about their bloods. If they are okay, and if their pulse are okay, mainly I'm talking about diabetic foot. If their pulse are okay, you can play around. You can change the dressing frequently, see how the discharge is. Sometimes I see patients every week. Sometimes I see patients every second or third day. So it's your assessment, and you know how it progress. So if that is progressing well, then you are winning. So you don't need to think about further management. Usually they settle. Just their pulse present. Venous ulcer, again, you can manage. I will just share that slides maybe in 2-3 minutes. How many questions more? Then I can finish.
So another 2 questions.
Okay.
The next question
No.
is if a,
yeah. Tell
shall
me,
I proceed?
Yeah.
Okay. If a venous ulcer coexists with a DVT, how should we manage in compression bandage?
Venous ulcer coexisting. Yeah. If it is a chronic DVT and a venous ulcer, yes, we see these kind of patients. You can manage these patients like a normal venous ulcer. sometimes they might need additional pressure, compression. But I think elevation and compression would do for the DVT. I'm not talking about the acute DVT. These patients are DVT, chronic DVT or post-thrombotic limb. So that patients, if the patient can elevate the leg, just that is the ideal way, and give some compression. So that is almost like a varicose superficial venous ulcer. You can manage a deep venous DVT plus a venous ulcer, but make
Next
sure
question.
patient is having pulse.
Okay. The next question is, what is the correct time to undergo SFL for a patient with slowly healing venous ulcer?
Okay. SFL, the evidence says venous intervention heal the ulcer quickly as well as prevent the recurrence. But again, SFL, I'm not sure. This is all for the endovascular, but I think the same principle applied to SFL. So initially, now the evidence is any venous ulcer, if you do a venous intervention, ulcer healing rate is high and it prevents the recurrence. But having said that, now you have like laser and radio frequency ablation and foam and all. So SFL is still available. Just still we are doing SFL in certain patient. But I would say if the patient is morbid and if the patient then consider for endovascular option rather than SFL because it's kind of invasive when you can compare with the endovascular. Yeah.
Thank you, sir. Those are the available questions.
Do I have time to proceed, or how many minutes? I have few
Okay,
slides
sir.
to share, right?
Okay, sir.
Okay. The venous ulcer, why I just keep the venous ulcer, I already told you. Because venous ulcer is the venous cause is the majority or major reason for the leg ulcer. So if you see 10 patients, I would say 75, here it's 85, yeah, 70%, 7 patients. So majority or 70-80% of the time, this is due to a venous pathology. So we can't if we are not talking about venous ulcer, the topic is not complete. So that's why I took the venous ulcer, and that is the majority of the GPs also manage the venous ulcer. So these patients come with a lot of symptoms, sometimes without an ulcer. So these are the major symptoms. They come to you: heaviness, tiredness of the leg, itching, cramps, burning, aching, these kind of things. And the ulcer typically at the malleolar site. Usually if it is along the great saphenous vein, or it can be at the lateral malleolus if it is related with the short saphenous. So if I'm only talking about the ulcer management, not about the varicose vein today. So if the patient comes to you with the venous ulcer, yes, there is a place for them to have an intervention. So the first one to go with is the venous duplex. You can assess the superficial vein and the deep vein. So usually we diagnose superficial venous reflux if the reflux is more than 0.5 seconds. And if the vascular surgeon is doing a duplex, they assess a lot of things to plan for the intervention as well. Diameter of the vein, how proximity to the skin surface, and how tortuous it is, and associated other things, DVT and post-thrombotic changes. So when a patient is having a venous duplex, if we can identify these things, you can plan the modality of the treatment as well. So nowadays you have endovascular, so you should know the anatomy about the vein and how proximity to the skin and how that what's the diameter, those kind of things, and the tortuosity you should know before you plan anything. So any patients with venous ulcer, usually any, I won't say any, but maybe half of the patients, they are obese. So think about other thing as well, right? Think about the weight loss. These patients, because they have multiple other problems as well associated with this venous ulcer, which is going on for years and years. So I see patients having ulcers for 20, 15 years. So these patients, we have to think about other part as well, and think about the exercise. They have arthritis, all sort of things. And nowadays, there are venoactive drugs. This is recently launched one. I don't know how effective it is, but it's available. And the one anyone can do is proper compression. So before you compress any venous ulcer, again, check the pulse. If you have a distal pulse, you don't need to worry. You can apply proper compression. But if you can't feel the pulse, I would say send the patient to a vascular surgeon. There are certain patients we can apply the compression, but before that we should see the ABPI and we should have a close monitoring how these wounds behave. So if you apply compression and if the wound is changing in color and if becomes ischemic and you are doing something else. So, and second one, if the patient already had a bypass surgery for their leg, in that case, I think these patients better sent to the vascular surgeon. Or I would say rather than applying compression, keep the leg elevated and see how these ulcers respond. Sometimes you might need to admit the patient for elevation. And if a patient is having a severe heart failure, also better to avoid compression, because sometimes these patients, the skin breaks and they get more and more ulcer. So if the patient is having minor symptoms, 15 millimeter mercury, and if it is lipodermatosclerosis, you can go for higher pressure. I would say we are talking about ulcers, so we can go for higher pressure if the patient is having distal pulse. So any venous ulcer, if they have evidence of superficial venous reflux, I'm not complicating anything because there are certain patients we think about DVT, chronic DVT with superficial venous reflux, but basically I'm saying, and if the patient doesn't have DVT and deep venous reflux, only the superficial reflux, I would say treat that first. So treating option one is initially you can start with the compression, but go for a definitive method. Nowadays, you have thermal, endovascular laser or radio frequency ablation, and you have foam treatment, guided foam. I would say guided foam because if you inject the foam to an artery, there's a high risk that patient can lose the leg. So go for a guided foam because we have ultrasound machines not freely available in the hospital. So use that ultrasound machine. And glue is available. I'm not used to the glue, and mechanochemical, that is also one of the method that is, I would say, not freely available in our country. And having said these things, the high ligation and stripping, just I know the laser is not freely available in all the hospital, but if the patient need treatment, yes, we might need to consider high ligation. But think about if the patient is obese, and if you are thinking that this patient can have a lymphatic damage and lymphedema in future, refer to a vascular surgeon for an endovascular rather than going for a open surgery. I'll stop there. Thank you. Any questions?
There are no more questions, sir.
Okay.
Thank you very much for your excellent lecture. And Participants, kindly fill the link in the chat box and kindly give your feedback and answer the post-assessment questions. Then you can receive your e-certificate for participation. Thank you all.
Thank you.